Welcome to another edition of Aesthetic Revolution, the podcast. I'm Dr. Ed Zimmerman, your host. Staci Taylor Zimmerman, the hostess, who will keep me from diving down any rabbit holes as we go and talk about subjects from forehead to feet in the aesthetic world. A little concentration in between, since even with 5,300 square foot of fun in our office, we still get an awful lot of people who want to know about that area. But today, I thought we'd come up and talk about something that's really important and we do a lot of in the office, and that's the doorway to the soul, the eyes. You know, when we meet people, we look in their eyes, we evaluate if they're healthy, if they're alert, if they're, if they're covert, if they're happy. The eyes are really the window to the soul, and they're very important in the overall aesthetic of the face. When people age, their eyes may sink into their head or appear to sink into their head a little bit, or they may be curtained and covered by tissue coming from above, or the fat pad down below may start to bulge out. So I thought we'd talk a little bit about the eyes and eye anatomy and how we do adjust those things around the eyes. And obviously the eyes are directly connected to the rest of the face, so they can't be taken totally out of the equation of the rest of the face. But there are a lot of things that we do with lids that are pretty fun. So aside from having a place to attach lashes to and put contact lenses or such on to give us different colors, people come in and they say, well, I'm tired of looking tired, or I don't know what's wrong, but there's something wrong here. And, we evaluate the eyes. So we start at the top, and certainly as we're losing a half to 1 teaspoon per year in the facial balloon, we're losing volume from up above on the scalp and the forehead, and the whole forehead slides forward, and it carries with it the brows. The brows are just kind of attached. There's only one muscle that lifts the brows up, and as that muscle gets thinner, and as that muscle is less supported by volume, because that volume puts the muscle on stretch, which lifts the brows and the extra skin appear to sit down on the edge of the lids, and this front part here where we put our makeup or mascara, it sort of disappears. And then the eyes start to get squinched shut. And then as the orbits change, so the orbits get bigger, the bone is taken away by Mother Nature, and the fat that is built around the eye to cushion the eye from injury starts to herniate out, or appear to herniate, to pseudo-herniate out. So we get bulges around the eyes, and then we get our malar puffs, our little allergic puffs, and then we lose our cheek volume. And the whole thing is just very aging. So
what a mess.
What a mess. Yeah. So people come in and they'll start to say, well, Doc, I don't have any place to put my mascara. And I say, you mean your anterior platform has minimized. But yeah, they don't have any place to put their mascara. And so the question becomes, do we need to revolumize the forehead? Because it's not just that their brow dropped, it dropped for a reason. Do we need to consider doing an endoscopic or a pretracheal forehead lift and actually lift that up, bring the forehead down? Is it something we can do temporarily with toxin, so we can allow the forehead to lift less opposed from the muscles that pull down around the eyes and the frown? What can we do? But a lot of times people want something more definitive, but they want to look natural. They don't want to have the over alert, over scared look. Their brows they've lost volume in the temporal area, and their brows may have come down laterally. That makes them look sad. Or they're frowning so much because of the lights and working on computers and such, their brows are now coming medially. That makes them look covert and angry and evil. So a lot of things that we can correct there, but sometimes we just have to do surgery. And I've been doing lids now since the mid-90s, and have gone to extensive training at Julestein Center and such, and worked with a lot of very talented facial plastics and oculoplastic surgeons, and it's a very humbling place to work. But the tenets of working around the eye and making sure that we cherry pick those people that need a little extra skin removed, or a little muscle removed or resuspended, or a lateral lacrimal gland that needs to be tucked back up under the bone so we don't get lateral bulging, and recognizing and honoring the ethnicities of the patients we're working with, because an Asian lid is very different from a Caucasian lid, is very different from, well, any other lid. So it's something that we try to recognize and really discuss with patients as we look together in the mirror and we look at pictures from earlier in life and see what the face used to support and how did the eyes used to be back in those days. And, I've been doing this long enough to have seen the pendulum swing, where it used to be you used to take everything away. You used to leave a large anterior platform and the eyes were pretty wide open and it wasn't a natural look. And now the pendulum has swung back and we don't take as much tissue. We strive for a more natural look so that the crevasse above the lid, the fornix, is less visible. And we still try to have a little bit from the distance from the underside of the brow to the tarsal fold, that's the crease inside, needs to be maintained a little bit more up and down than sucked in. But we still like to have the medial canthus come in and be a little more sculpted, so that the eye doesn't look as puffy. And then we look at the level between the medial canthus and the lateral canthus. In a more youthful eye, the lateral canthus is a little higher. And the lateral canthus controls the tightness of this lower lid up against the eyeball. And as we get older, if that lower lid ligament relaxes or stretches or becomes unattached, the eyes open up. You have scleral show and you have dry eye syndrome. So we want to make sure that when we're doing these surgeries, we keep the lower lid up tight. We try not to cut into the lower lid. That's called a canthopexy, canthoplasty. So we try not to cut into the lower lid to tighten it and then sew it shut, because it actually makes the width of the eye smaller. So we try to keep that full width of the eye so that you can have a nice normal eye. The measurement of the eye is critical in sculpting. The measurement of the eye we like to think of as the width of the eye is the same distance as you would have between the medial canthus of the two eyes, is the same distance as you would have from the lateral canthus going laterally to the side of the head and the scalp there. So 5 eyeballs across is kind of the ideal proportion for most of us, depending on genetic heritage and such, to have a nice sculpted, beautiful contour. And the rule of fifths is what we talk about when we're doing sculpting. Where the brow is critical. Is the brow at the level of the edge of the orbital bone, or in women, we like to see it a half a centimeter to a centimeter higher, especially laterally, so above the lateral colored part of the eye, of the pupil. Guys can have more of a lower, flatter brow. They're allowed to have that. See captain's eyes. And we don't want to take too much tissue over a male upper lid. If we take that away, it feminizes the eye. But if we have a woman who's very heavy lidded, we want to take a little bit more, if she's been able to support that earlier in life, to feminize the eye and open it up and allow people to see into the soul. And so those are all things that we think about when we evaluate the eye. Of course, we're looking for, when we pull this tissue down, does it snap back immediately? And when we pull it away from the eye, how far can we pull it away, indicating whether this ligament is intact and whether there's enough elasticity for the lid to snap back and decrease our risk of dry eye syndrome. We want the lids to be able to come together. When the upper lid comes down and touches the lower lid, it's actually touching a pool of tears, like a bucket of paint. And so as that comes back up, it spreads the tears over the surface of the cornea. And that's why we don't have dry eyes. But as our hormones change and we have less estrogen and such, we make less mucin. So the tear components change. And so we have more wateriness to our tears, less mucin to our tears, and that can contribute to dry eye as well. So lots of things going on. We're operating around the eye, not in the eye. But all these things have effects. So we evaluate the eye and we take measurements. We want to make sure that we have enough skin between the lower part of the brow, wherever we set the brow, and the edge of the lashes, that the eye can indeed close. So we have a minimum number of millimeters there, within reason. It changes depending on the opening of the orbit and such. And we want to make sure that the eye appears to have an elevated lateral canthus. Otherwise, we need to take that and reattach it up to the edge of the orbital bone there, the tubercle where it used to be attached. So that's called canthopexy, for just using suture to kind of reattach it back up where it used to be, and that keeps things nice and tight. Sometimes we'll use some laser resurfacing to tighten the tissue, to tighten this very thin skin, the thinnest skin on the body, around the eye so that it contours nicely like a blanket over whatever's underneath. And sometimes we have to sculpt the fat pads. So maybe I think let's talk about an upper blepharoplasty first, because that's more common. We certainly see patients who come in who had blepharoplasties decades ago, and they're over-resected here. And if we're very careful, sometimes under ultrasound guidance, we can use a blunt cannula, and we can, with the proper numbing, slide the cannula across from laterally to medially, and we can fill in just a little bit of this fornix. Always on the move, tiny amounts of a hyaluronic gel, so that we're not impairing the lid movement or anything like that. And we can restore so that the eye doesn't look as sunken. We can restore that volume, and it actually makes the lid function a little better and look nicer. But some people just have too much tissue. And after they've had their evaluation by their eye doctor to make sure there's no underlying glaucoma or dry eye syndrome or any of those other things that would keep us from doing elective eye surgery, we very carefully measure both when they're sitting up and lying down to be able to determine how much tissue we can take. With some people, it's just skin. With some people, we're taking skin and the muscle underneath, which is the orbicularis oculi muscle, the muscle that goes around the eye like a donut, and when it contracts, it causes crow's feet or happy lines. And we're taking a little shaving of that muscle, and underneath that muscle, underneath the septum, are the fat pads. We've got a medial and sort of a central and lateral fat pad, and sometimes out here on the lateral side, particularly in people who are very heavy lidded, we'll find a little bit of the lacrimal gland, the tear gland, that has herniated and sunk down. It just needs to be attached back up under the bone so this area doesn't bulge anymore. And once we get all that done, we're able to very carefully resect the extra skin, muscle, and fat. Usually, I was educated that if you had very heavy lateral skin, you needed to come out and extend your incision into the smile line so that it didn't just stop and leave a bulge here at the edge of the eye. So we tend to contour out laterally. I use a CO2 laser to do all of my incisions. That allows me to bevel the skin edges and work on a bloodless field without actually having anything touching the skin. The laser is 1 millimeter or 2 away from the skin, and it vaporizes a 0.25 millimeter incision across, a layer at a time. So I have a great deal of control, and I can get down to each layer of the anatomy and know where I am. And if their brow is too heavy, I can use that same incision to extend upwards to the periosteum at the edge of the orbit, slip under the eye, avoid the supratrochlear and supraorbital nerves, avoid the vessels off to the side here, and I can resuspend the brow from the underside of the brow and attach it to the periosteum so that the lid can go up, but it doesn't go down as far. So my sutures actually are holding the brow from the backside, so it allows it to go up and it doesn't allow it to go down as much. And the sutures are just there to hold it in place until the tissue scars back down, but it keeps it up a little bit so that if they relax after their blepharoplasty, the brow doesn't come down and just ruin the results of the blepharoplasty because they didn't have enough volume in their forehead. So we talk about volume in foreheads and things like that at the same time. Now, a lower lid blepharoplasty can be done one of several ways. It can be done from an anterior approach, a direct blepharoplasty, but that's more associated with some pull down. And hey, matey, nobody likes the scleral show there. So most of my patients are reasonable candidates for a transconjunctival laser-assisted blepharoplasty, which is to say that after we've made the marks for the medial and the central and lateral fat pads kind of fall together and attach together there, then we're able to very carefully shield the eye from the laser. The eye is, of course, numb, and patients are in their happy place, kind of floating in their twilight in our accredited operating room. And I'm able to use the laser to make an incision about 10 millimeters back from the gray line, from the edge of the lower lid and very carefully expose the fat pads below into view. I've got my magnification and my lighting and all that kind of stuff, and it's critical to have a really good assistant who can expose the operating field for you and make the tissue billow equally on both sides so that they don't put more pressure on one side than on the other side. So you only take what you're given by Mother Nature. You try not to take more because you don't want to have the eye look too concave there. And very carefully sculpt out the medial fat pads. The medial fat pads are much more vascular. They have scary, gigantic, huge, under magnification blood vessels there. And obviously, if you have a blood vessel that is not controlled, then you can have a bleed that goes around to the back of the eye. It's called a retrobulbar bleed. It could put pressure on the optic nerve, and that can be a surgical emergency where they could go blind. So we'd really rather be very careful and cauterize those blood vessels as we go. The laser helps me do that, but we also use jeweler's forceps and electrocautery and things like that. And there's a muscle that comes underneath that allows the eyes to turn down and in. We have to sculpt the fat pads on either side of that muscle. I don't do a lot of moving of fat. I've not been satisfied with that, and I've had such great success with fillers under the eyes that I don't try to move fat and have it sutured down across the edge of the orbit to take care of a defect or an indent here. I'd rather do that in my world with a hyaluronic gel, even if it's directly put in under surgery or ultrasound guidance. And because those fat pads don't dependably stay, sometimes they move, sometimes they don't. I think they're a great idea. I just haven't had great success with them, so I go with the things that have worked for me over the decades. And when we do our transconjunctival laser-assisted lower blepharoplasty, once the tissue is smooth, there's no incision visible on the outside. We just pull the tissues together, let the conjunctiva just rest against each other. It serves as a little bit of a pressure relief valve if you ever had a bleed. And we recover the patients there in the operating room, and they're able to get wheeled out to their car and go home and have their meals and kind of take it easy, keep their head up for the next few days. We generally see them, we talk to them that night and maybe the next day, and we generally see them back in 3 to 5 days. And life goes on. So cover the topics a little bit.
Yeah, for the most part. Let's talk real quick about the festoons. We get a lot of patients that call, especially around spring when allergy season is up and, people are having some issues with the bulge underneath their eye, not knowing that it can be caused by two different things and knowing the difference. Let's talk about that real quick.
Okay, which two things are you talking about? Because I'm not a mind reader.
Well, fat versus like a mylar.
Okay, so fat versus fluid-ish, if you will.
Right.
Okay. Yeah, so, and the other thing that we see a lot of festooning is filler that has either been misplaced or has migrated for whatever reason. But yeah, there are plenty of people who've never had filler, who've never had surgery, and they have what's usually sort of a triangular malar festoon here. It starts out there, but because of the ligaments that come across and support the eye and hold the eye and the cheek in place, as we lose volume, those ligaments become more visible. And the festoon, which is like a sort of spongy, water-filled tissue, but it's not that you can put a needle in and pop it and get the water out. It's just sort of a macerated mess under the skin. And what we're doing now with those, we've tried a number of things over the years. We've tried injecting them with steroids because we think that part of that may be an inflammatory process. We've tried various forms of energy, which have either under the tissue when we're doing a transconj lower bleph, we can go and we can cauterize the tissue and contract the fibroseptal network a little bit. That's actually been fairly successful. And we're working on a new system now to do that with microplasma. So our Rejuvenation system with the new micro handpiece, we're looking at going in and tightening the fibroseptal network and the ligaments a little bit, from either a remote insertion site or while we have the tissue open and can see it under direct vision. We've also done laser resurfacing, and that's been kind of a cool thing where if you can support the tissue from underneath, relieve the inflammation, and shrink wrap it from above, that seems to be the best of all worlds. And then there occasionally, generally guys, will be someone who's got such huge water bags under here that I've literally cut them out. And the CO2 laser leaves a very fine, usually whitish, but a very fine line, which has been an acceptable exchange for getting rid of the huge bubble that sags down. I mean, some of these festoons literally hang down like a Dunlap. It looks like just a bubble of skin hanging off their face, and we're able to resect that. We again have to be careful, because between the thicker skin of the cheek and the thinner skin right underneath the eye, the cheek skin will win in a pull down, and that would pull the lower lid away from the eyeball, which would not be a good thing. So we have to be careful how we do that and make sure we have plenty of support. I don't put any of the barbed threads into that area. The area needs to move freely, and it's so mobile with expression that I'm not a fan of putting threads in this area to try to either elevate the lateral brow temporarily or to hold the cheek up. I'd rather work with the tissue, work with fillers, and observe under ultrasound the way the different layers slide in order to make sure that we have our fillers at the right place. So that's all part of the art of rejuvenating the eye, and it's really the periocular area. So kind of cool.
Yeah, kind of cool. And, I think one of those things that when patients come in as we're getting older, that seems to be a big focus is the eyes.
You said focus.
Yeah, I said focus.
Okay.
But no, it is. It's a common thing for people to be not happy with. If I feel like it's the first thing that we see when we're aging is the heaviness in our eyes.
So people come in, they get their lids done. The recovery is pretty straightforward. They're going to go home that night, keep their head up. A Ziploc of ice chips or peas or corn, not cauliflower, but something that'll just wrap around the surface, and their eyes may be a little bit blurry as the anesthesia wears off, because I do tend to do one eye and then the other eye, so they have to catch up, and all the anesthesia has to wear off. And of course, so a little bit of blurry vision, occasionally a little bit of double vision, but hopefully none of that, and it should all go away by that night or the next morning. Then as they're starting to feel better, there could be some bruising. There isn't always. Sometimes there's remarkably little, but there could be some bruising that comes to the surface at day 3, 4, 5. Whatever bruising they have that they don't have at that point, that's all they're going to have, and it's generally going to be done and gone by the 2-week mark. So they can be out and about. If they have sutures in the upper lid, these little fine hair-like sutures generally either dissolve, or I take out what's left of them at about 7 days.
People are usually back to work pretty quickly too.
Yeah.
I mean,
you had
on a Thursday and back to work on Monday. It's
some people just got off the table and went back to work.
Well, yeah.
So it just depends on the human. You get it does feel a little weird, a little nummy there, but you get over that. And you have to be careful when you're putting your mascara on your newly revealed anterior platform, that area does stay numbish for a while, sometimes 3 to 6 months, and you have to be careful that you don't poke yourself in the eye when you're putting your makeup on, because it's so exciting to have a place to put makeup. And if we do carry the incision a little out to the happy lines, that incision gradually, although it starts out a little thicker than the lid itself, that incision gradually becomes less and less thick, less and less visible as part of the healing phase that matures over the course of a year and becomes pretty much part of the face, and people don't recognize there was ever anything done. And that's the goal, is to look like you just had great genetics, that you inherited a nice restful weekend, things are going well in life, and you have great eyes. So, all right, well, the eyes have it. That's a little bit of discussion of upper and lower lid blepharoplasty and browpexy, as we call getting that brow to kind of lock in place and not come down after we've done an upper lid bleph. We touched on canthal positioning with canthopexy and canthoplasty, and making sure that you're reviewed by your eye doctor before we do anything elective. So thanks for joining us on another edition of Aesthetic Revolution, the podcast. Like, look, listen, ask questions, all that kind of stuff. And we'll look forward to seeing you again on the next episode. Thanks for watching.